To start off with the pathophysiology of Parkinson's disease, or PD, I have selected 3 of the most evidence-based risk factors or causes. Firstly, we have oxidative stress caused by toxic ion accumulation, understood to be the most substantial modifiable risk factor for PD. Progressive disruption to ion homeostasis, or excess ion levels in the substantia nigra pars compacta, or SMPC, of the brain is a direct cause of oxidative stress. Oxidative stress will lead to neurodegenerative disease due to oxidative damage-induced cell death. Secondly, disruption to protein homeostasis caused by cellular stresses, a great example being the oxidative stress we have just discussed, and loss of mitochondrial membrane potential will trigger dysregulation of mitophagy, or degradation of damaged mitochondria. This means that unhealthy or damaged mitochondria will not be lyased and replaced, thus hindering their ability to generate the energy necessary for reactions in our cells. Lastly, there is also a genetic disposition to PD in mutations of the PINK1 and Parkin genes. Genetic abnormalities in these genes can be either hereditary or caused by mitophagy dysregulation, so this is all very interconnected. These mutations cause selective loss of NMPC dopamine neurons, which project into the basal ganglia, which is responsible for transmitting biochemical signals in the motor cortex and thus conduct motor output. Damage to these dopamine receptors is linked to the hyperreflexia and psychiatric symptoms we see in PD. As we understand, all of these factors are causing damage to the dopaminergic neurons in the basal ganglia of the SMPC, either from oxidative stress, mitochondrial degeneration, or mutations to genes. This damage will induce Lewy bodies accumulating in the brain and spinal cord. Lewy bodies are protein deposits that are released from the degeneration in the SNPC and lead to dementia and cognitive impairment that we see in PD. Indeed, in a study conducted, 96% of autopsies of individuals with PD had an accumulation of Lewy bodies in their brain. Secondly, and most significant to the clinical manifestations of PD, is that there is decreased dopamine production caused by damage to the dopaminergic neurons in the basal ganglia. This decreased dopamine will act on the direct and indirect basal ganglia pathway, causing the effect of decreased movement initiation while concurrently increasing movement inhibition. This decreased movement will firstly decrease the excitatory output and input to the motor cortex, thereby causing bradykinesia or slow movements, as well as hypokinesia or decreased movements, manifesting symptomatically as shuffling gait, freezing or resting tremors. Secondly, the inhibition of the rectalospinal tract pathway will increase, causing hypotonia or impaired regulation of muscle tone, manifesting as rigidity. Furthermore, postural reflexes become impaired due to hypotonia, manifesting as postural instability. For the treatment of PD, a common medication uses levodopa, commonly combined with carbidopa. Levodopa's primary indication is Parkinson's and is used to manage motor system changes associated with the disease. It is classed as a dopamine precursor and is an aromatic amino acid. The degeneration of the NSPC seen in PD causes a substantial decrease in dopamine, as we have discussed. So what is levodopa's mechanism of action? Levodopa acts by crossing the blood-brain barrier into the presynaptic terminals of dopaminergic neurons, where it undergoes the process of decarboxylation, resulting in an end product of dopamine. Once released into the synaptic cleft, dopamine can be taken up or metabolized by various enzymes. This increase in dopamine levels helps to replenish the levels depleted in Parkinson's, improving motor function symptoms. Carbidopa is a decarboxylase inhibitor, which is administered with levodopa to increase the bioavailability of levodopa in the brain. When levodopa is taken alone, the presynaptic clefts in peripheral tissues of dopaminergic neurons will also take up the drug, and dopamine is unable to cross the blood-brain barrier, thus diminishing its therapeutic effect. Indeed, the dopamine produced in peripheral tissue will cause unwanted effects such as cardiac arrhythmias, nausea, and vomiting. Thus, in Emma's stay as nurses, if we do notice that levodopa is being administered without a dopamine decarboxylase inhibitor, we may want to flag this with our doctors or monitor her heart rate, chest pain, and nausea more frequently. The most significant and critical nursing consideration for levodopa is that it is a time-sensitive medication. We must strictly adhere to individualized levodopa regimens as even a 15-minute deviation from dosing intervals specific to our patient can exacerbate symptoms of the disease, such as tremors or rigidity. In Emma's case, this is extremely important as she experiences postural instability alongside these painful symptoms, meaning she could very much so have a fall. Furthermore, it is important to consider that high protein foods can interfere with the absorption of levodopa, so taking the medication 30 minutes prior to meals would be preferable if it fits with Emma's dosing regimen. It is also important in Emma's case that we monitor her for common side effects of levodopa, including sleep disturbances and postural hypotension, as both sleep deprivation and a drop in blood pressure can contribute to her increased falls risk. We should also monitor her bowel movements closely, as a combination of her decreased mobility alongside the use of levodopa can decrease bowel movements. We can consider managing this with encouraging fluid intake and the use of PRN medication like Caloxyl Senna. Lastly, in long-term use of levodopa, a phenomenon known as the wearing off effect may occur, in which the medication's therapeutic effect diminishes at a faster rate between doses. In this case, it is important to know our patients well and pay keen attention to detail in their baseline functionality, and when we may notice a decline or they may communicate suspicion of an exacerbation of their symptoms, we should change the dosing regime with. These are my resources.